We're going to be talking about post-operative management, although some of the concepts that we talked about in the first talk obviously apply in the post-operative period and vice versa. So we're mainly going to be focusing on these perioperative issues of residual cardiac lesions, diagnosing residual lesions, bleeding, post-pericardiotomy syndrome, the acute management of pulmonary hypertension. Dunbar Ivy is going to be talking to you in detail later this week about primary pulmonary hypertension, so we're not going to get into that. Some extracardiac postoperative complications, assessment of QPD-QS in the shunted single ventricle patient, and then we'll briefly, if we have time, touch on mechanical circulatory support. Chris Almond is going to be here Friday afternoon. He's an internationally recognized expert in mechanical circulatory support, and he will certainly cover that in more detail. We're not going to talk about postoperative arrhythmias. Frank Zimmerman has a couple hours with you later in the week for those issues. So thinking about residual cardiac lesions. So the etiology of a residual cardiac lesion after cardiac surgery could be broken down into three buckets. One is an incomplete preoperative diagnosis. There are data from Boston Children's that approximately 2.5% of neonates who undergo cardiac surgery at that center, which has an outstanding imaging program, can, at least as of a few years ago, had an incomplete preoperative anatomic diagnosis that impacted the postoperative course. You could know the anatomy perfectly well, but there could be a technically inadequate operation. That's probably the most common issue, right? That there's distortion of the pulmonary arteries after a shunt or residual aortic arch obstruction. And finally, and probably least commonly, you could have a failed therapeutic plan. That's a scenario where you know the anatomy, the operation was technically perfect, but with the benefit of hindsight, maybe that operation wasn't the right operation to perform in that patient. And the classic example would be a neonate with small left-sided structures that somebody decides to do a two-ventricular repair as opposed to a Norwood operation. So in terms of how the patients present with a residual lesion after cardiac surgery, well, the easy ones or the obvious ones are where they can't come off a bypass, they end up on ECMO in the operating room, or they've got an obvious low cardiac output state because their aortic arch is still obstructed early after cardiac surgery. We're not going to miss those. But the more difficult patients to pick up are the child the infant or child who's stuck on the ventilator after cardiac surgery, perhaps due to left atrial hypertension, a residual left to right shunt with overcirculation, or perhaps there's tracheal bronchial compression by some vascular structure. So often these patients are able to wean them down to low ventilator settings, but when you extubate them, they end up getting reintubated. And then there's the patient who everybody swears up and down is had a perfect repair, but they just keep developing infections, and they're stuck in the ICU with culture negative sepsis and that sort of thing. Your radar should go up. If you come on service on a Monday and the baby's 2 weeks post-operative from an operation and still stuck on the ventilator and has culture negative sepsis, in my mind, that's a big red flag that there's something else going on. So how do we identify these patients? Well, there's no simple test. There's no one right answer to pick up on these lesions. It's a multifactorial approach. You really need to know the preoperative anatomy, the patient's physiology, what testing was done, and particularly what testing was not done. A patient who may have needed a cardiac catheterization but didn't have it before surgery. What sort of clinical state were they like going into the operating room? A patient who comes in from home is going to have a very different postoperative course than that baby who's been on a ventilator in the NICU for 3 or 4 weeks before they go to the operating room. You really need to get a detailed sense of the intraoperative course, both from the surgeons and the anesthesiologist, about how the patient behaved in the operating room, what were the intraoperative findings, exactly what did the surgeon do, how big did they make that atrial fenestration, how long were they on bypass, what amount of inotropes did the anesthesiologist need to help get the patient off bypass, what were the TE findings if one was done, what filling pressures were measured, what gradients were measured, and particularly what gradients were not measured after the operation. Did they check the arch repair or not? In the postoperative period, it's a serial examinations, serial laboratory assessment, serial testing of assessment of vital signs. But I think perhaps the most important thing is putting all those data together and having an appreciation for the usual postoperative course for that cardiac defect who's undergoing the particular operation in your center with your surgeons. How does those patients usually act? And then when the patients deviate from that course, it should raise your index of suspicion for residual lesions. Looking at blood pressure, if your pulse pressure is widened, you think you may have residual aortic regurgitation. For example, after a truncus repair, there could be residual systemic or aorta to pulmonary collaterals leading to runoff. If the pulse pressure is narrow, you wonder about cardiac tamponade or low cardiac output syndrome. Arm-leg gradients, very helpful. We should check them frequently. Keep in mind that 5% of patients with a coarctation of the aorta or hypoplastic left heart syndrome will have an aberrant right subclavian artery coming from the descending thoracic aorta. So if you're measuring the blood pressure in the right arm and one of the legs, and there's a residual coarctation, both of those blood pressure measurements are going to be coming from below the area of the coarctation, and thus they're going to be the same. There won't be any gradient. I've seen people make important long-term decisions by banking on these 4 extremity blood pressure measurements in the setting of an aberrant right subclavian. So you don't want to do that. Also, if there's poor ventricular function, you may only have a 5 or 10 millimeter arm leg gradient in a patient with hypoplastic left heart syndrome who's got an important residual coarctation and decreased function. The treatment for that patient is to go to the cath lab or back to the operating room and fix to the arch, not to go for a cardiac transplantation, at least as a first step. And again, just keep in mind this concept of paying attention to your end organ perfusion pressure, which again, I'll remind you is calculated by subtracting your CVP from your mean arterial pressure. It's much more important than end organ perfusion pressure than just your systolic or diastolic blood pressure for most patients. Looking at your right atrial pressure, your CVP, your right atrial waveform, or your CVP waveform, is made up of 3 positive waves. Most important are your atrial A wave, which is produced during atrial systole, and your V wave, which is produced during atrial filling, and then 2 negative waves here. So you can see these waves labeled on the tracing here relative to the QRS complex. If your right atrial pressure is elevated after cardiac surgery, you're thinking there's a problem with right ventricular function or compliance. You could have residual tricuspid valve disease or regurgitation, a residual left ventricular to right atrial shunt, generalized volume overload, cardiac tamponade, or arrhythmia. Obviously, if your right atrial pressure or your CVP is relatively low, you got to consider the possibility of inadequate preload. So again, if the right atrial pressure is low, the patient's otherwise doing well, we don't necessarily chase that number. Again, it depends on the clinical context. What about your left atrial pressure? So normally in young children and infants, the left atrial pressure is normally about 2 to 7. It's typically a little bit higher than that after neonatal or infant cardiac surgery. So in the high single digits, maybe even 10 is an appropriate left atrial pressure. If your left atrial pressure is elevated, the differential diagnosis is listed on the slide here. Elevated left ventricular end diastolic pressure for a variety of reasons, mitral valve disease, a large residual left to right shunt that results in increased pulmonary venous return and filling of the left atrium. That could either be a septal defect or residual aorta pulmonary collaterals. The generalized volume overload will elevate your left atrial pressure, arrhythmia, and tamponades. So if I was writing a question about these intercardiac pressures for you on the boards, I would probably show you a tracing like this one where you've got a Canon A wave and ask you what the differential diagnosis was or which of the things on a list of potential answers could cause that tracing. So to get Canon A waves, that either implies you've got AV dissociation, accelerated junctional rhythm or JET can cause that, marked first degree heart block, or AV valve stenosis. On the other hand, if you're shown a tracing that has a prominent V wave on your atrial trace, the main thing that would cause that is systemic AV valve regurgitation. So what about your pulmonary artery pressures? Well, obviously in the current era, we rarely have direct pulmonary artery monitoring in the early postoperative period. It's probably a couple of patients a year in most centers. Your normal pulmonary artery pressure is less than 25 millimeters of mercury after the first few weeks of days to weeks of life. If your pulmonary artery, you do have a pulmonary artery line and the pressures are elevated, the differentials listed here again, anatomic obstruction of the pulmonary arteries or veins. Don't forget about the pulmonary veins if you've got a problem with elevated PA pressures. If your left atrial pressure is elevated for all the reasons we just discussed, that's obviously going to also elevate your pulmonary artery pressure. An important residual left to right shunt will do it. Pulmonary vascular disease or elevated PVR. Rarely in children, a pulmonary embolus can be the underlying problem, and some potential respiratory issues as well can contribute to elevated pulmonary artery pressures. What about intercardiac oxygen saturation levels for looking for postoperative residual lesions? So if you're measuring your oxygen saturation levels from catheters in the right atrium and they're inappropriately elevated for what you would expect for that patient, things to think about include a left atrial to a right atrial shunt or a left ventricular to right atrial shunt. Unrecognized anomalous pulmonary venous return to the SVC or right atrium can cause that. If you got increased systemic oxygen delivery or decreased consumption, that's going to influence your right atrial sats. Probably one of the most entertaining things that I see is you have a patient with an umbilical line that's thought to be in the right atrium, say a transposition patient who's waiting for surgery, and there'll be 3 or 4 venous blood gases in a row where the venous oxygen saturation level is higher than the oxygen saturation level that is being drawn from the umbilical arterial line. So what can cause that? People will read these numbers off on rounds sometimes and not even, it doesn't even occur to them, but what would be the cause of that? If you're uncorrected transposition, waiting for surgery, he's got an umbilical venous line with a saturation level that's higher than the arterial saturation level drawn from the umbilical artery. You always got, the question is where's the tip of that line, and if the line's gone across the PFO and it's hard to tell it on the AP x-rays we get in the ICU, you could be sampling blood from the pulmonary veins. So anyhow, catheter malposition can sometimes give you spurious data that can confuse people. If your right atrial saturation is reduced, you start thinking about all the different causes of decreased systemic oxygen delivery that we talked about earlier, or increased oxygen consumption, fever, agitation. If your arterial oxygen saturation levels and content are low in a patient with cyanotic heart disease, obviously your right atrial oxygen saturation levels are going to be proportionally lower. So what about your left atrium? Well, normally your left atrial sats, if you draw sats, which we don't do commonly, but occasionally from the left atrial line, they should be fully saturated, assuming you don't have important lung disease. If your left atrial saturations are reduced, you may have an atrial right to left shunt, or you could have pulmonary venous desaturation from pulmonary edema, pneumonia, RSV, et cetera. Pulmonary artery catheter, if you've got one, and the pulmonary artery sat is elevated, that could be because you've got a residual left to right shunt. Peter Lang, who was involved with this course for many years, wrote a classic paper about 30 years ago in which he looked at the pulmonary artery oxygen saturation levels the first night after tetralogy flow repair, and this is back in the pre-TEE days, was able to demonstrate that if your pulmonary artery sat early after a TET repair is greater than 80, there's a high likelihood you're going to have an important residual VSD when they brought those patients back to the cath lab, which they routinely did back at in that era at 1 year of age for a diagnostic catheterization. What if your pulmonary artery sats are low? It's similar to if your right atrial sats are low by and large. You've got either decreased delivery, increased consumption, or underlying cyanotic heart disease. So the first step once you get past your routine clinical data to evaluate for residual lesions is almost always echocardiogram. Keep in mind that you can do a TE in the CICU if your transthoracic windows are inadequate because the chest is open or the bandages, whatever the case may be. As far as cardiac catheterization, that was the old gold standard. The conventional dogma is, and one of the things that makes people nervous about cath, besides the contrast and the field trip and the potential for bleeding related to the catheters and whatnot is the disruption of suture lines. But there are a couple papers from different centers that have shown up in the literature in the last decade or so that demonstrate that most fresh suture lines can be safely dilated in the cath lab, particularly if you use a stent, much sooner than 6 weeks after cardiac surgery. But I think the nuances of how that suture line was created and what type of suture was loose are important. And that's an instance where there needs to be a detailed discussion between the surgeon who performed the operation and the interventionalist. In recent years, we've sort of either to decide whether to do a cath or we've been getting cardiac CT scans in postoperative patients when they're concerned about residual lesions, either to rule certain things in or out, or to at least create a roadmap for the catheterizers so that they know what they're getting into heading to the cath lab. So I was fortunate to be part of a study where we recently looked at residual cardiac lesions after pediatric cardiac surgery in a cohort of over 84,000 patients whose data were available in the Society of Thoracic Surgeons Congenital Heart Surgery database. And what we found and we defined unplanned cardiac reintervention in the study as either a transcatheter intervention or an unplanned cardiac reoperation before the patient went home from the hospital after that index cardiac operation. And we found that nearly 6% of all patients in the STS database underwent an unplanned cardiac reintervention. Not surprisingly, they were more common in neonates than they were in infants and older children. It was also not a surprising finding that the more complex the index operation was, the greater the rate of unplanned reintervention. So for a Stat 1 mortality category operation like an ASD repair, it was only 1.5%. But for Stat 5 operations like the Norwood, it was as high, it was nearly 20%. We look for independent risk factors for unplanned reintervention, and not surprisingly, aside from younger age and greater surgical complexity, there were a number of other important independent risk factors, including lower weight, the presence of non-cardiac comorbidities, being on the ventilator before going to the operating room, et cetera. The types of unplanned reinterventions, the most common thing was placement of a permanent cardiac pacemaker, but other fairly common reasons included revision or placement of a systemic to pulmonary shunt, either adjustment or takedown of a pulmonary artery band, mitral valve repair, replacement, and pulmonary artery reconstruction. But there were, in the database, there were 186 different codes for the type of unplanned cardiac surgical reinterventions. The SDS data set does not have data regarding the types of unplanned cardiac caths, so they were counted in those initial numbers that I showed you, but I don't have details about what type of catheter interventions. But you can imagine that many of those are going to be on either the aortic arch or the pulmonary arteries, or potentially stenting of shunts. This is a univariate analysis showing the substantial relationship between the need to perform an unplanned cardiac reintervention and operative mortality. It was nearly 19% if an unplanned reintervention was needed, only 2% if not. And this held up following a very detailed multivariate analysis. So the need for an unplanned cardiac reintervention is an independent risk factor for mortality after pediatric cardiac surgery. None of these findings I think are earth-shattering, but they sort of call attention to the magnitude of this problem. Most patients do well after cardiac surgery current there, but some of them still do not. And those are patients we need to focus our efforts and energy on. All right, so postoperative complications. What about bleeding? It happens about 1% to 2% of the time. Anecdotally, it seems to be partly dependent on center and the surgeon in terms of how much time they spend drying up in the operating room. The etiologies from a pathophysiologic point of view include platelet dysfunction and consumption, inadequate heparin neutralization, dilution of clotting factors while on bypass, occasionally fibrinolysis, and then the surgical bleeder. Risk factors for postoperative bleeding that we anecdotally see and have been reported in the literature, including reoperation, cyanotic heart disease, and operations that require extensive aortic suture lines. The treatment is multifactorial. One of the first principles in the ICU is to maintain control of the systemic blood pressure. So you don't want a patient who's actively bleeding to have to be hypertensive. And we use vasodilators typically, or a drug like esmolol to address that. Obviously, replacement of red cells and clotting factors, platelets is needed. You can consider giving activated factor VII, which is typically very effective in controlling non-surgical bleeding after cardiac surgery, but you run the risk of developing clots, either of the shunt or your ECMO circuit, so you need to be careful with that drug, and certainly I would have a conversation with your cardiac surgeon before administering it. Antifibrinolytics are commonly used. These are typically started and managed in the operating room by the surgeons. If the PTT is prolonged, that could be a sign that there was inadequate heparin neutralization, and you can consider giving protamine to reverse that heparin effect. And then a general rule of thumb to have in mind for surgical bleeding is that you need to consider re-expiration if your chest tube output continues to be more than 5 cc's per kilo per hour, despite attempts at medical management. So cardiac tamponade, this can be insidious, and yet it's something that can take a otherwise very salvageable patient and lead to a bad outcome if it's not recognized. So tamponade occurs when you have compression of your cardiac chambers. It can be from blood, from clots, from air, and occasionally if you've got mediastinitis, from a pus collection in the mediastinum. The underlying pathophysiology is that you've got decreased diastolic filling. The patients don't come in if they've been an outpatient, they're coming back. They don't come to the emergency room and say, I've got a pericardial effusion, but they'll have these vague either respiratory symptoms of dyspnea or cough, or potentially GI symptoms because the venous return is getting backed up into the mesenteric circulation. Some of the common signs you would expect to see are listed on the slide here. I'm not going to read these for you. I just did want to point out this regarding pulsus paradoxus, which is defined as a greater than 10 millimeter mercury decrease in systolic blood pressure with inspiration. A couple of things about this. One, even in a cooperative patient, I find this very hard to measure anecdotally, particularly if you don't have an arterial line in place. And secondly, it's not very sensitive or specific for cardiac tamponade, and it's rarely present in neonates and rarely present in patients who have residual intercardiac shunts. So the bottom line is you can't hang your hat on that finding. It's a nice thing to talk about with the medical students and the residents on rounds, but I wouldn't go to the bank with it. If you happen to have an EKG, you can see decreased voltage or even electrical alternans if there's a large effusion. Your chest x-ray findings, if the effusion is developed acutely in the early postoperative period, the cardiac silhouette size could either be normal or only mildly enlarged, so it may not jump out at you. It takes a long time, and we'll talk about this more in a second, to develop those large water bottle effusions that you see in the textbooks of the sort of classic chest x-ray finding with a pericardial effusion. Obviously, echo is obviously very helpful for confirming the presence of an effusion, quantifying its size, and potentially finding a target for the interventionalist or intensivist who's going to drain the effusion if it's needed. But keep in mind that the cardiac tamponade is a clinical diagnosis. So if you think the patient's got tamponade and they need to have their chest open, and echo is not readily available, I wouldn't wait for somebody to come in from home to do the echo to have somebody reopen the chest. If you think they've clinically got tamponade, you should probably open the chest early on in the process. And certainly tamponade should be considered in the differential diagnosis of any patient you're evaluating with a low cardiac output syndrome after cardiac surgery. So this figure depicts the relationship between the accumulation of volume over time on the x-axis and the interpericardial pressure on the y-axis. And as you can see, if there's a rapid accumulation of fluid over a short period of time, it takes a very small amount of volume to cause tamponade physiology. Whereas if you've got the typical outpatient, the 4-year-old ASD repair who's been home for several weeks and then comes back with a very large pericardial effusion, that effusion is likely accumulated slowly over time, and the pericardium's had time to stretch, so you can get a lot of fluid in that pericardial space before the patient develops tamponade and reaches the limits of the pericardial stretch. So this brings us to post-pericardiotomy syndrome. This can occur days to weeks after a cardiac operation. Anecdotally, it seems to be much more common after simple operations like an ASD repair or partial anomalous pulmonary venous return repair. The etiology is unknown. It's thought to be potentially an autoimmune component, perhaps exacerbated by a viral intercurrent illness. These patients can have a low-grade fever, complain of chest pain. It can easily be mistaken for a intercurrent viral illness. The exam findings you may find are listed on the slide here. Typically, if you have a friction rub, that implies there's a small effusion, not a large one. The echo can be helpful, and again, the treatment would be usually a combination of NSAIDs, corticosteroids, at least initially, and then consideration for drainage or even a pericardial window for recurrent effusions. When performing a pericardiocentesis, there's sort of two pieces to this procedure. The one is the actual act of performing the procedure, which is it's conceptually simple, right? You're just taking a needle in the subxiphoid space, aiming for the left shoulder, and if you've got echo guidance, you're targeting the largest pocket of fluid available. I've anecdotally found it technically challenging to perform, and I think in most centers, if the interventionalist is available, they're the folks who are performing these procedures. But I think the thing as cardiologists and intensivists that we can pay attention to is the patient's volume status, sedation issues, and pain control. And it's very important, and somebody's got a potential evolving or is actually in tamponade, to maintain cardiac preload. So while you're waiting to set up for the procedure, these patients do the best first-line interventions you can do to stabilize their blood pressure and keep them stable, particularly after you give sedation, is to give volume, to try and distend that right atrium and fill the heart better. Putting these patients to sleep and instituting positive pressure ventilation can precipitate cardiovascular collapse. So if you can do this with a patient spontaneously breathing with sedative agents like ketamine, for example, that may be beneficial. The potential complications that can develop from the procedure are listed on the slide there: myocardial perforation, coronary artery injury, pneumothorax, or tachyarrhythmias. So things to watch for in the immediate period after the procedure if you're monitoring the patient in the hospital with an interpericardial drain. So pulmonary hypertension. So Dunbar Ivy is going to be here later this week and is going to talk about this in detail. I'm just going to focus on pulmonary hypertension in the acute setting in the cardiac intensive care unit. So the basic mechanisms for patients develop pulmonary hypertension included underlying increased pulmonary vascular resistance, long-standing increased flow to the pulmonary vascular bed, and increased pulmonary venous pressure, either due to a problem with the pulmonary veins or the mitral valve or the left ventricle. Often there can be a combination of those factors, but the net result is the patient develops an increased arterial or smooth muscle mass and tone. And then, so you've got that underlying substrate, and then in the perioperative period, either before or after surgery, the pulmonary vascular reactivity can be influenced by a number of factors. One is the severity of the degree of underlying pulmonary hypertension, obviously, the location and size of your preoperative left to right shunts, and this tends to be more prominent in patients who've got long-standing arterial left to right shunts, like an unrecognized aortopulmonary window. Another fairly malignant complication is a patient, for example, who's both cyanotic and has increased pulmonary blood flow. And the classic example would be a patient who's an infant who was late to be recognized to have detransposition with a large VSD. So that patient's going to be both cyanotic and have increased pulmonary blood flow, and that's a setup for having a very reactive pulmonary vascular bed after cardiac surgery. Cardiopulmonary bypass in and of itself can cause the pulmonary vascular bed to become more reactive due to inflammatory mediators, reductions in nitric oxide production, and increase in production of endogenous molecules that promote pulmonary vasoconstriction, like endothelin-1. You can develop microemboli to the pulmonary vascular bed and leukosequestration, and then in the postoperative period have atelectasis. We see that commonly, and hypoxia from all the usual causes. And then things that we're doing for caring for the patients postoperatively can exacerbate pulmonary hypertension, such as painful procedures, suctioning of the endotracheal tubes, sort of the classic one, and inadequate provision of oxygen and mechanical ventilation. So all that being said, as you probably all know, the incidence of pulmonary hypertensive crisis is fairly uncommon in the current era because we correct most of these lesions early, which is a good thing. But the flip side of that is that people aren't as used to being aware of it in the most at-risk patients, which are encountered uncommonly, and managing it. So when you do have a pulmonary hypertensive crisis, there's an acute increase in right ventricular afterload. This causes an adverse ventricular and ventricular interactions such that the normal crescent-shaped right ventricle becomes more oval-shaped and compresses the interventricular septum. That in turn compromises left ventricular filling. The patient can develop elevated left atrial pressure, significantly reduced lung compliance. They can be very difficult to bag during one of these episodes. Bronchospasm can be present, presumably from the acute dilation of the pulmonary vascular bed compressing on the tracheal bronchial, particularly the distal bronchial tree. Hypercarbia and hypoxia can ensue, and a state of right ventricular failure, low cardiac output from both ventricles, and eventually cardiac arrest can develop. If there's a systemic pulmonary shunt in place or a septal defect, the initial presenting symptom can be profound cyanosis. But if it's a two ventricular type situation without septal defects or a shunt, you're typically not going to see cyanosis until much later in the, or hypoxemia until much later in the episode. In terms of treatment, well, obviously, prevention is key. So empiric strategies in at-risk patients and the first-line treatment may include interventions such as ultrafiltration in the operating room. In the postoperative period, we want to try and blunt the stress response with narcotics, potentially keeping a patient muscle relaxed overnight to avoid agitation and dysynchrony with the ventilator. You want to keep the pH in the 7.4 to 7.45 range, so slightly alkalotic. Adequate oxygenation of PO2 over 100 would be ideal. You want to maintain FRC and avoid atelectasis, so large tidal volumes at a low rate are better than 5 or 6 per kilo tidal volumes at a high rate for preventing atelectasis. Milrinone can be helpful. It's a pulmonary vasodilator. And then in at-risk patients, you could either consider empirically using nitric oxide or starting it in the first sign of trouble. And I did want to call your attention to a randomized clinical trial that came out of the Melbourne group several years ago, in which they were weaning patients off of nitric oxide. And they found in this placebo-controlled trial that the use of sildenafil was very helpful for preventing that rebound pulmonary hypertension that occurs when you stop nitric oxide. So that's a very sort of good trick that you can have up your sleeve. If you come in one morning, you're rounding, and they say they stopped the nitric last night, and the patient's PA pressures went up, reacted like a pulmonary hypertensive crisis. Now we're sitting here stuck on 20 parts per million of nitric oxide again. What are we going to do? In this trial, they used just a one-time dose of sildenafil that was administered an hour before the nitric was stopped, and it was very effective for preventing those rebound episodes. Some patients will not have a reactive pulmonary vascular bed, but it will be fixed. We occasionally, but less commonly, encounter these in the cardiac intensive care unit. This can be either due to anatomic factors, such as patients with pulmonary atresia MAPKAs, or patients with arteriopathies like Williams syndrome or Alagille syndrome, or occasionally, even in the current era, we'll still get patients who are hospitalized with Eisenmenger's physiology. And the ICU management for these patients, I know Dunbar probably will talk about this in a little bit more detail, but from the ICU perspective, it's mainly supportive care. We want to support the RV function with inotropes if needed, avoid hypotension because that can precipitate RV coronary ischemia and lead to a bradycardic arrest. So paying attention to induction agents that are used for these patients during sedation, that sort of thing. And then we can talk to our colleagues about creating some type of patients with a two ventricular circulation, creating a pop-off if it doesn't already exist at either the atrial, ventricular, or great vessel level, which can allow some right to left shunting to maintain left ventricular preload at the expense of cyanosis. So I wanted to briefly mention this POT shunt procedure, which has come up recently. The POT shunt is a connection that is placed between the descending thoracic aorta and the left pulmonary artery. And in a patient with severe pulmonary hypertension, that can allow right to left shunting from the pulmonary arteries to the descending aorta, right, to decompress the right ventricle and allows a pop-off, allows some maintenance of cardiac output. But the oxygenated blood that's ejected from the left ventricle going to the head is still fully oxygenated. So your coronary arteries and your brain are still going to see fully oxygenated blood, but you're going to have deoxygenated blood created through this pop-off going to the descending aorta. So just a little bit of trivia for you. Who knows, besides my friends back there in the fifth row, who knows who Willis Potts was? after the Potts shunt was named. Willis, seems like nobody else in the room except the Chicago folks. Willis Potts was the first congenital heart surgeon at Children's Memorial Hospital, which is Northwestern's Children's Hospital here in Chicago. It's now called Lurie Children's Hospital, but he devised this Potts shunt as an alternative to the Blalock-Taussig shunt for surgical palliation of neonates and infants and young children with cyanotic heart disease back in the 1940s. And that's probably what he's perhaps most known for as one of the early pioneers in cardiac surgery. So some extra cardiac complications that can develop after cardiac surgery, phrenic nerve injury is one of them. The mechanisms can be due to transection, stretch, electrocautery injury in the operating room, cold injury. The incidence is probably 1% overall for cardiac operations. The patients undergoing a shunt placement or aortic surgery are particularly at greater risk because of the course of the left of the phrenic nerves through the mediastinum. Neonates and infants who have a phrenic nerve injury tend to be more compromised than older children because of their greater reliance on the diaphragm to support mechanical ventilation and their higher chest wall compliance and the relative underdevelopment of their intercostal muscles. So these patients will have thoracoabdominal dyssynchrony once they're extubated after cardiac surgery, which can lead to reduced ventilator insufficiency and potential reintubation. The patients may end up being stuck on the ventilator, not able to wean. They may fail extubation and be reintubated. They can have persistent atelectasis on the afflicted side, and you may often see an elevated hemidiaphragm, particularly when they're no longer receiving positive pressure. To make the diagnosis, if the patient's on the ventilator, you can either do this by echo or by fluoroscopy, but the patient needs to be spontaneously breathing and not receiving positive pressure. So these tests need to be coordinated with the radiology folks or the cath folks who are performing them so that you don't inadvertently mask the presence of a priest hemidiaphragm with positive pressure. Then as far as management, for an older child who separates from the ventilator, fine, it's just expected management. But neonates and infants who are stuck on the ventilator or can't seem to get off positive pressure often will benefit from a diaphragmatic plication. And some of these tend to resolve over time if the nerve was just stretched or bruised in the operating room, but certainly some of them do not, and can be a long-standing issue. Another postoperative complication that we not rarely encounter is chylothorax. I listed some risk factors on there. Syndromes, particularly Turner syndrome, can be problematic. Patients who've got elevated innominate vein pressure, typically the Glens and Fontans, but also a patient who has postoperative right-sided heart failure would be at higher risk because the thoracic duct drains into the innominate vein on the left side of the chest. And then obviously patients who've got clots either in their SVC or their innominate vein that causes back pressure into that thoracic duct. Sometimes the diagnosis is fairly obvious, right? There's that milky fluid coming out of the chest tubes, but if you're unsure, you can send their triglycerides and lymphocyte counts to the lab, and you'll see that you've got a predominance of lymphocytic fluid and an elevated triglyceride count in that pleural fluid. Some complications from significant and prolonged chylous chest tube drainage are listed on the slide here. And the management then is sort of an iterative process over time depending on how long the drainage has been going on and the volume of that chest tube drainage. So almost all patients will start off by being switched from a human milk-based formula to a medium-chain triglyceride formula. If that doesn't work, NPO, they may need a chest tube if there's a large effusion. And then you start getting into the muddy areas of whether a trial of octreotide is helpful or a thoracic duct ligation is the next step. Many of you, if you've been to the meetings, national meetings recently, have probably heard about the very exciting work that's being pioneered at the Children's Hospital of Philadelphia for lymphatic embolization of the thoracic duct for patients like this who've got prolonged refractory high output chylous chest tube drainage and other lymphatic disorders like plastic bronchitis and protein-losing enteropathy. So, that's always a logistical challenge if you're thinking about either trying that for the first time at your center or transferring a fragile postoperative patient who's stuck on a ventilator to another institution for an intervention like this. But it's certainly something to be aware of and worth considering. I want to talk a little bit about some of the issues that pop up in palliated neonates after cardiac surgery. And, one of the things to keep in mind in the current era, we used to always think about balancing QP to QS in these patients, but in the current era with the size shunts that our surgeons use, which are smaller than they were, 20 and 30 years ago, the issue of balancing QP to QS is generally less of an issue for most, but not all patients. And the biggest focus has been shifted towards maintaining your QS, or your systemic blood flow. That's because your QP to QS is determined by your balance of your systemic vascular resistance, assuming the arch is unobstructed, the size of your connection to the pulmonary artery, which I just said is typically more appropriately regulated in the current era. So pulmonary vascular resistance becomes less of a factor for most patients. So if you've got a neonate who's undergone surgical palliation and is cyanotic, there's a large laundry list of things that can cause that. And I'm not smart enough like you guys to remember all those things, right? So I have to divide it up in my mind into buckets and make it very simple. And I do that by thinking about things that can cause pulmonary venous desaturation, and those are listed on the slide here: pneumothorax, a pleural effusion, pneumonia, that sort of thing. Things that can cause systemic venous desaturation. And this is an easy one, right? It's either decreased systemic oxygen delivery or increased systemic oxygen consumption, and we talked about that earlier, so you evaluate and treat for those things. And then if neither of those pans out, you're still scratching your head as to why the patient's blue, you start thinking about decreased pulmonary blood flow. And that could be because of elevated pulmonary vascular resistance. I think that's a common excuse, but in reality, probably an uncommon mechanism for most neonates. Pulmonary venous hypertension, a restrictive ASD if you've got also severe mitral stenosis or mitral atresia, distortion of the pulmonary arteries, a small shunt, or a tight pulmonary artery band. Another mental model that people use when they're thinking about these patients, they ask, are the hemodynamics preserved? And if the answer is yes, and you just got low CoP to QS, you've either got a pulmonary artery problem or some type of problem with pulmonary venous desaturation. On the other hand, if you've got a low cardiac output state, you may have a high QP to QS with overcirculation, again, uncommon in the current era, or an underlying low cardiac output state. But then the evaluation for these patients is pretty simple, right? Anything that in a neonate that can cause pulmonary venous desaturation, you're almost always going to see on the chest X-ray. In terms of evaluating your delivery and consumption, we talked about that earlier, but knowing how many boxcars you got with your hemoglobin level, your arterial venous oxygen saturation levels, your heart rhythm, findings on echo, you can usually sort that out and direct treatment accordingly. But it gets a little messier when you're trying to figure out whether they have decreased pulmonary blood flow, and if it's not obvious from your echo imaging, you may need to think about a CT or a cardiac cath. Now, what about low cardiac output in the neonate who's been palliated? The differential diagnosis is listed on the slide here: myocardial dysfunction, residual lesions of either the AV valves, the aortic valve, or the arch, arrhythmias, overcirculation, as we just discussed. We just talked about the evaluation for these patients, and then the treatment is going to be driven by the underlying etiology, and often it's a multifactorial treatment. So what about the superior cavopulmonary anosis, either the Glenn or which is performed in most centers, the Hammy-Fontan operation? This operation serves to reduce volume load, minimize AV valve regurgitation potentially if it exists, and optimize the preload and afterload of that single ventricle to make these patients better candidates for their ultimate Fontan operation. So common problems that we see, sort of routine problems after the Glenn in the early postoperative period, is hypertension. That's probably due to the more efficient circulation, because the single ventricle now just only has to pump blood to the body and not to the lungs anymore. Some of that's going to be from volume overload and pain in the early postoperative period, but hypertension is a common problem. Chylothorax, because of the elevated pressure in the innominate vein in the thoracic duct, and then the irritability or the Glenn headache due to that acutely elevated CVP, right? Their CVP has just gone from, in the course of one day from 5 to 15 or so millimeters of mercury. But a subset of the Glens, particularly the salvage Glens or an early Glen that's done, can have SVC syndrome that can be characterized by very high SVC pressure in the high teens, causing edema of the face, neck, and upper extremities. These patients can have important, cyanosis due to the development of veno-venous collaterals that expand early after surgery. And the treatment for SVC syndrome in a Glen is multifactorial, maintaining a low mean airway pressure, manipulating the pH. We'll talk about that some more in a second. And sometimes just patience is required because usually it will improve over time if there's not a major residual anatomic problem. If you got a patient who's blue early after cardiac surgery, again, there's a large laundry list of things that can cause this. To simplify it, I break it down into pulmonary venous desaturation, things you can pick up on the chest x-ray, systemic venous desaturation, again, either high consumption or low delivery. You sort that out by assessing these variables, and then decreased pulmonary blood flow. And again, if it's not obvious after your sort of non-invasive testing, you need to start thinking about a CT or a cardiac cath. Now, the physiology of patients with a Glenn is interesting in that the cerebral and their pulmonary circulations run in series together, right? And these pulmonary, the cerebral vascular bed and the pulmonary vascular bed are both auto-regulated by oxygen, carbon dioxide, and your pH, but they go in the opposite direction of each other. So the question is which one dominates? And in the cerebral vascular bed, we know that the patients generally vasodilate with hypoxia, right? If you're not getting enough oxygen to your brain, the autoregulatory response is to vasodilate and get more blood flow. Hypercarbia, and you can remember that by remembering that patients with traumatic brain injury that you encountered during your residency, there was a lot of attention by the ICU staff about making sure they're not hypercarbic because that's going to increase cerebral blood flow and potential swelling to that injured brain. And acidosis will also dilate the cerebral vascular bed. The pulmonary vascular bed does the exact opposite with all of those things, right? So the question is which one dominates? And there was a series of papers published initially by Scott Bradley, who's my current surgeon that I work with at Medical University of South Carolina about 15 years ago, and also some papers from Toronto that have very nicely shown that it seems like the cerebral vascular bed dominates in that if you hypoventilate a patient who's cyanotic after a Glenn operation, you will get a fairly predictable increase in systemic arterial oxygen saturation levels. And it's probably by a combination of having increased cerebral blood flow, which means there's more blood flow coming back through the Glenn pathway, and probably secondarily affect if you've got a mild acidosis that can generate endogenous catecholamines, which can improve your cardiac output and minimize your systemic venous desaturation. So that's an important concept to be aware of. A blue Glenn can sometimes be very helped by hypoventilation rather than hyperventilation. Fontan patients with a low cardiac output state, one of the first things to do is look at their intracardiac filling pressures. If they're both low, that patient may need volume, may be bleeding. If the Fontan pathway pressure is high and the left atrial pressure is low, that suggests a problem somewhere along the pathway or in the pulmonary artery bed, or that could be a sign of if a patient had a fenestration that it's acutely clotted. But if both the Fontan pathway pressure and the left atrial pressure are high, then you need to start thinking about problems on the systemic side of the heart, such as ventricular function, AV valve regurgitation, arrhythmias. Fontan patients blue, I go through the same algorithm as we have here below. The only thing that's different is if you look at the causes of decreased pulmonary blood flow. In the Fontan, you need to think about different things like a baffle leak or an oversized fenestration or a clot in the Fontan pathway. Some of these patients will have pulmonary arterial venous malformations. They typically went into the Fontan operation with them. That's a situation where you need to be aware of the preoperative testing and then expect that patient's SATs to be lower for a period of time after cardiac surgery. A period of weeks to months, actually, until that hepatic factor kicks in. All right, cardiac ECMO. We could spend hours talking about this. I've listed some relative indications and contraindications on the slide here. They tend to vary by center and by team. I'm not going to go through that in detail for the sake of time. 3 questions you should ask, even if you're not the intensivist. If you're standing at their bedside as a consultant, your patient goes on, or the cannula, when they go on ECMO, are the cannulas hooked up correctly? Or do we have adequate systemic perfusion, and particularly patients who've got aortopulmonary collaterals, or they've got a systemic to pulmonary shunt, not a Sano shunt, by the way, but a systemic pulmonary shunt off the aorta. Those patients are going to need more ECMO flow to support their end organ function because of that runoff than a patient who does not have those anatomic features. And finally, is the left ventricle adequately decompressed? Does the patient stop having pulmonary edema? Does the left heart look smaller by echocardiogram? So it's very important to decompress that left ventricle, get your left ventricular wall stress down, get your myocardial oxygen consumption down in that injured heart in order to optimize your chances for myocardial recovery. And by decompressing the left ventricle, you also keep the lungs in better shape so that you've got a chance for either early ECMO decannulation, a successful trip back to the operating room, or conversion to a VAD therapy if needed. It's important to keep the lungs open. It's important to consider early anatomic investigation for cardiac patients who end up on ECMO. And this is a sort of old paper from Karen Booth from Boston Children's. They looked at nearly 200 cardiac patients who ended up on ECMO, and the punchline here is that nearly 60% of these patients, after they went to the cath lab, had an intervention either in the cath lab or a trip back to the operating room. And they were able to catheterize these patients even 2 decades ago quite safely, even though they were on ECMO. So being on ECMO is not an excuse not to go to the cath lab. It's probably a reason to go for a lot of patients, and the yield is often very high. ECMO outcomes after ECMO are not great. Only at best about half of these patients will survive the hospital discharge. Some of the risk factors are listed on the slide there. Patients with cavopulmonary connections, the Glens and Fontans, are particularly challenging. For the sake of time, I'll let you read through this slide on your own. And as I alluded to earlier, ECMO and ECPR should be considered for patients who have a refractory cardiac arrest for the right patient in the right setting. Chris is going to talk to you on Friday, I believe, about VADs. So for the sake of time, I'm going to skip over that. And then I think what we're going to do is just wrap up with a couple more questions to assess your digestion of these principles. So why don't we jump to the questions right now. So the first question, a 4-month-old underwent a bidirectional Glenn operation. Your ventilator settings include a respiratory rate of 18, a PIP of 23, PEEP of 5, and FiO2 of 40%. Your tidal volumes are 10 per kilo. Chest x-ray reveals well-positioned tubes and lines and clear lung fields that are expanded to 9 to 10 ribs. Your last arterial blood gas was a pH of 7.4, PCO2 of 40, and a PO2 of 29, so this Glenn is blue. The acute intervention most likely to improve systemic arterial oxygenation is A, start inhaled nitric oxide, B, increase the respiratory rate to 24, C, decrease respiratory rate to 14, D, increase the PEEP to 8, or E, increase the FiO2. All right. So the majority of you, looks like about 70% picked up on this contact that I talked about with Dr. Bradley's work about the fact that hypoventilation can improve oxygenation in patients with Glenn physiology. There's prospective data in the literature that in general, inhaled nitric oxide doesn't do much to improve oxygenation early after the Glenn operation in patients who are blue. That assumes that the patient was appropriately prepared with their initial palliation and that they didn't have excessive pulmonary blood flow leading up to that Glenn. Increasing the respiratory rate has been shown by Dr. Bradley and others not to be helpful. There'd be no reason to increase the PEEP, right? I said the chest x-ray was clear, the lungs were already well expanded, and again, if the chest x-ray is clear, FiO2, again, while it's a pulmonary vasodilator, the PVR is probably not high in this situation, and the x-ray was clear, so there's not alveolar lung disease that providing additional supplemental oxygen would necessarily be helpful. Next question. Number 3. So a 3-year-old who's now postoperative day 1 from a lateral tunnel fenestrated Fontan operation. Last night when you left, this is how it's always the case, he was doing great. His heart rate was 125, blood pressure 90/56. The CVP in the Fontan pathway was 15, and your common atrial or left atrial pressure was 8. He was on some milrinone just because, even though, as I told you earlier, that data shows it doesn't do very much in this situation. The ventilator settings included 40% oxygen, respiratory rate of 14, inspiratory pressure of 22, PEEP of 4, with a resultant tidal volume of 12 cc's per kilo. Your last ABG, the ABG last night was 7.4, PO2 of 40, and PO2 of 55. So this morning you come back the next day and this kid's in trouble now. His heart rate's 148, blood pressure is 74/38, CVP 22, common atrial pressure 5, your blood gas is pH of 728, PCO2 of 40, PO2 of 120. Currently ventilator settings and tidal volumes are identical to the night prior. The arterial lactate has risen to 8, and the patient is now oliguric. The most likely explanation for the deterioration in clinical status is A, a large pleural effusion, B, excessive Milronone effect, C, inadequate minute ventilation, D, a clotted fenestration, or E, accelerated junctional rhythm. This question is obviously intended to troubleshoot after the Fontan operation. All right, so this one, about half of you got this one right. The correct answer is D, a clotted fenestration. So I presented the classic scenario when a fenestration clots, your CVP goes up, your left atrial pressure is low, the PO2 and the blood gas went up, right? It went up from 55 or so to 120. So they're not using that fenestration, they're not shunning right to left anymore. And some patients can clot their fenestration, they're perfectly fine, they never needed it. Other patients will clot their fenestration and get sick. If you had an excessive Milronone effect, you would be hypotensive, but not necessarily have an increase in PO2 or a increase in your CVP. Large pleural effusion, you wouldn't expect your PO2 to go up. Inadequate minute ventilation, I told you the CO2 was 40 the next morning, so you're ventilating the patient okay. And an accelerated junctional rhythm would cause both your CVP and your left atrial or common atrial pressure numbers to go up. So that's sort of a lengthy question, but it tests the concept. And I guess I'm waiting for somebody to say, well, why didn't you extubate him last night instead of leave him on the ventilator overnight? He might have done much better. And that's a good point. Early extubation of patients with cavo-pulmonary connections is generally a good thing, and more centers are doing that either in the operating room or very early in the first few hours after admission. So probably the mistake in this case would have been leaving the patient on the vent overnight. All right, next question, which I think is number 5. A neonate underwent repair of truncus arteriosus, including ASD and VSD closure, and placement of an RV to PA conduit. Overnight, the patient had tachycardia, recurrent hypotension, oliguria, and worsening metabolic acidosis, which was treated with escalating inotrope support bicarbon volume. Left atrial pressure is now 7 with normal A and V waves. The CVP is 17. Blood pressure 65 over 40. Systemic oxygen saturation is 99%. The most likely etiology of the hemodynamic instability in this truncus repair is A, junctional ectopic tachycardia, B, a residual VSD, C, a large residual ASD, D, restrictive right ventricular physiology, or E, septic shock. I'll give you a hint. If somebody tells you on the post-operative day 1 that a patient has septic shock, that's like a big red flag in your, I mean, it could happen, rarely happen, but it usually means there's an underlying cardiac problem. It'd be just unusual to develop sepsis that early after surgery. All right, that's pretty good. The correct answer here was D, restrictive right ventricular physiology. And the hint in this question was patients after neonatal truncus repair or neonatal TET repair often have restrictive right ventricular physiology, right? You've got VSD patch on one side. In the case of tetralogy, you got a thick right ventricle, and then the other side of that ventricle, the surgeon makes an incision to put the right ventricular conduit. So that right ventricle is going to be unhappy after those neonatal operations. And as I said up here in the first line, if the ASD is completely closed and there's not a pop-off left or a PFO for right to left shunning, and a subset of these patients are going to get sick with that physiology, and I've seen this over the years. So if you had junctional tachycardia, I would expect there to be canon A waves. I'd expect the left atrial pressure to be higher than 7. If you had a residual VSD, I'd expect the left atrial pressure to be higher than 7, right, if there's a big residual left to right shunt. If the PFO is left too big or there's a large residual ASD, how's that patient going to present? And they've got a sick right ventricle. They're going to be blue, excessively cyanotic, and I've seen that to the point of, the PFO seemed like it was okay in the operating room, but functionally it was too big, and the patients are excessively cyanotic and end up on ECMO, and they have to go back and get their ASDs restricted. And then septic shock, I think we covered that one.
A 5-month-old who underwent tetralogy for lower repair, the fellow calls you at home the evening of surgery that reports that the patient developed fever and SVT at 240 beats per minute that has not responded to adenosine. They do rhythm strip following the third dose of adenosine at 0.3 milligrams per kilo via peripheral IV and a quick IV push is effects to you. The patient's blood pressure is now 50/30 milliliters of mercury. Taking into consideration the AHA PALS guidelines for pediatric tachycardia with a pulse and poor perfusion, you recommend the following. A, an additional dose of adenosine of 0.3 milligrams per kilo given through a central line. B, an IV amiodarone of dose of 5 milligrams per kilo over 20 to 60 minutes. C, IV procainamide, 15 milligrams per kilo over 30 to 60 minutes. D, IV crystalloid of 10 cc's per kilo. E, synchronized cardioversion 0.5 to 1 joules per kilo. Please look at the effect of adenosine on this rhythm strip, and based on that, choose your answer. This is a little tricky question. So most of you answered E, probably based on the fact that the patient is hypotensive and has poor perfusion. But the key to this question is what's the effect of adenosine on the rhythm? And for Dr. Costello, this question requires some IV crystalloid, and I'll expand on that. So when you look at the rhythm on top, it's hard to figure out where the P waves are. But when you give a dose of adenosine, you see a slowing of the heart rate that shows you that there's a P wave before every QRS. So the reason why this patient was hypotensive and had poor perfusion was probably because he was sinus tachycardia from hypovolemia. So in his question, he felt that given the effect of adenosine on sinus rhythm, that just shows slowing, that the best therapy for this patient was to treat the underlying cause, which is giving IV crystalloids. It will be reasonable to consider if the patient further deteriorates and you don't know what the underlying cause, to just go ahead and cardiovert if you feel the rhythm is the rhythm you have to cardiovert. But what happens normally with sinus rhythm is that there will be little effect to none from cardioversion, and you may actually get into some bad territories with new rhythms. So none of the antiarrhythmics will be appropriate based on the fact that this is sinus rhythm. 2 days after repair of obstructed TA-PVR, a neonate has developed a metabolic acidosis with a lactate of 11. An echo demonstrates good biventricular function, but systolic pulmonary artery pressures at systemic levels despite 80 parts per million of inhaled nitric oxide. The pulse oximeter has a good waveform and reads 98. Her arterial blood gas is a pH of 7.4, CO2 of 39, and a PaO2 of 35, an oxygen saturation of 65% measured by co-oximetry. The most likely explanation for the discrepancy between her pulse oximeter and co-oximetry oxygen saturation level is A, an air bubble in the blood gas syringe, B, a prolonged duration of time between when the blood gas was drawn and analyzed, C, an elevated methemoglobin level, D, an elevated carboxyhemoglobin level, E, right to left shunting through residual ASD. What condition of the ones represented there gives you a discrepancy between the saturation that is seen and the saturation that's measured? Choose your answer. Excellent. So an elevated methemoglobin level is exactly the answer of a discrepancy of all those choices between a co-oximetry measure oxygen saturation and a pulse oximeter. And it's usually associated with high amounts of either nitric oxide and some of the toxicities that increase methemoglobin. So the air bubble and the blood gas probably will give you a different read in most of all the values, so the pH and CO2 and the PaO2. Prolonged duration within the time the blood gas was drawn and analyzed. Sometimes will give you, some discrepancies in the pH. An elevated carboxyhemoglobin level should not actually give you a discrepancy in those two values, and right to left shunting to residual ASD should not give you a discrepancy between the co-oximetry measure oximetry and pulse oximetry. In this baby? Oh, the PaO2? Because, well, I'd imagine the baby has pulmonary hypertension after TA-PVR. I mean, I didn't write the question, but I'm just guessing. And they put him on high-dose nitric oxide. The usual dose of nitric oxide is not 80. And the reason for that, the reason why it's 20 normally and not even 40, is because of the higher risk of methylhemoglobinemia with high doses of nitric oxide. So yes, that's why they kept the baby on nitric oxide, I imagine, for the low PaO2 after total vein repair. To answer your question, but I'm guessing that's kind of how you thought about it. So an important point that Dr. Perridon made earlier was that you can think about why is it that the PaO2 is low, and then come up with an alternative explanation. But what is the question trying to ask you? And the previous question is, what will be the reason why there is discrepancy between a co-oximetry measure of saturation and a pulse oximetry measure of saturation? And that is what the question is trying to ask you. I want, from all the choices you had there, which one is the one that best explains that? Question number 6, a neonate with hypoplastic left heart syndrome remain on room air until day of life 3, when he underwent an uneventful stage 1 Norwood operation with placement of a 3.5 modified Blalock Taussig shunt. He's now postoperative day number 2 and remains cyanotic with PaO2 of 30 millimeters of mercury. He's receiving mechanical ventilation with an FiO2 of 0.3 and PEEP of 5. The arterial pH has been anywhere from 7.4 to 7.45 on most of the postoperative blood gases. He's afebrile, receiving sedation, also relaxant, and has been adequately diuresed. Milbrinon is the only cardiovascular infusion. There is no residual aortic arch gradient by arm and leg blood pressure measurement. The chest X-ray has clear lung fields, and hemoglobin is 15 grams per deciliter. A limited echo revealed normal right ventricular systolic function and mild tricuspid regurgitation. Further images were unable to be obtained due to the limited ultrasound windows related to the open chest. The most likely primary cause of this patient's systemic hypoxemia is A, low cardiac output, B, pulmonary hypertension with elevated pulmonary vascular resistance, C, increased oxygen consumption, D, ventilator-associated pneumonia, E, a residual anatomic defect either involving the BT shunt or pulmonary artery leading to inadequate pulmonary blood flow. Please choose your answer. Great. So there are a couple of ways to think about this question, and you can see how there's several reasons why you'll be less concerned with adequate provision of oxygen content. The hemoglobin is 15, so you're well tanked up from that end. You're not acidotic. The FiO2 for now is 0.3, but by the time you get to be in trouble with a PaO2 of 30, you normally have cranked up probably the oxygen a little bit more. The fact that you see normal function goes back to the schematic that John put up on what are the causes of hypoxemia after cardiac surgery. One of them will be decreased systemic venous saturation. The other one will be decreased oxygen delivery. And the last one will, or decreased oxygen content. And the other one will be decreased pulmonary venous saturation. Knowing that the chest X-ray is clean, knowing that you have adequate function, knowing that you have adequate hemoglobin, the only possible answer that is left here is to investigate is a residual problem.